I'm going to ask my co-chair, Dr. Breen, to talk about intermediate and high-risk PE. And she is so qualified to do this. She set up and runs our local PELT team, our pulmonary embolism lysis team at Guy's and St. Thomas's, and has a lot of data on this. So over to you, Karen. Thank you for doing it.
Thank you very much, Beverley. So I am going to share my screen, hopefully. And okay, so I hope everyone can see that now. Okay, so thank you very much for inviting me to talk today on the management of submassive PE and how to use your local PERT team. And Raza has already sort of alluded to some data in terms of how we risk assess these patients who present with PE. So first of all, I think one of the ways to illustrate some of the cases we deal with is to present a case that's very fresh in my mind. So this is a lady who presented to us on Friday, and I think it's a really good illustration of how important it is to have a multidisciplinary team and management of these patients who present with PE. So we have a 63-year-old lady, and it was a particularly difficult case because she had come in having been bedbound for 6 months due to depression. She was brought in by ambulance mainly because she fell out of bed. Her BMI was pretty significantly elevated. And when she had a CT thorax, abdomen and pelvis, she was found to have extensive bilateral PE. So she had clot basically in the central, segmental and subsegmental vessels. Her pulse was 80, her blood pressure was, her systolic was in the high 80s with the diastolic in the high 40s. That was despite fluid challenges, and she had oxygen saturations of around about 94 to 95% on room air. Her BNP was 11,000. We then went on to manage to get an echo later that day, and she had what appeared to be signs of a right ventricular thrombus, and also on her CT thorax abdomen pelvis had signs of thrombosis in the common femoral vein, although it was very difficult to do Dopplers, technically speaking, because of her elevated BMI. So I'm just going to leave that case there for you all to have a think about, and we'll come back to that case later to discuss what actually happened. So we've already discussed that there's a range of severity and how PE presents. Some of them are incidental, and we have lots of really new improvements in technology and imaging. So there's a lot of questions around whether we should even treat some of these incidental subsegmental PEs. Patients are asymptomatic, and it's picked up often on screening, cancer screening imaging for those patients undergoing treatment. We've just talked about standard or low risk PE, and then we move on to think about the sort of category of submassive PE. Massive PE is in many ways is a little bit more straightforward. So you have those patients who come in with significant collapse. They have a drop in their systolic blood pressure, so it's usually less than 90, or it's more than a decrease of 40 milligrams from their usual systolic, and that's sustained for more than 15 minutes. This is the way 5 to 10% of patients present who present with PE, and we know that it has a really significantly high mortality. So those patients often undergo, well, they're recommended that they undergo systemic thrombolysis, and that's mainly because we know that these patients really do have a significant risk of death. But of course, there is a significant risk of major bleeding with systemic thrombolysis, particularly intracranial hemorrhage and GI bleeding, but it's been shown to outweigh the risk of death from PE. So going to the European Society of Cardiology guidelines that were published in 2019, I think this is a really useful diagram that helps us illustrate why PE can basically cause death in patients. And it's the acute right ventricular failure that's the main cause of death in these patients who present with acute PE. So I think this is a really nice illustration of all of the different steps and how this sort of increase in the right ventricular afterload can lead to death and poor outcomes in many of these patients. And that's why it's particularly important in patients who present with a significant clot burden that we have some form of assessment of their right ventricular function in order to be able to categorize their risk of poor outcome from PE. So I think we're all aware of these types of patients who present, and often it's really difficult to know what to do with them. And again, just to reiterate the point that it's really important to consider the assessment of the right ventricle in these patients, because that's going to tell us and give us a prognosis on how these patients are going to do. And it is recognized that actually in a lot of cases, that's very poorly managed and often not even done in an emergency setting. And one of the outcomes from their recently published NCPOD results, so the National Confidential Inquiry in Patient Outcomes and Death, did discuss management of PE, and often it alludes to the fact that patients don't have timely imaging, they don't have markers performed of right heart strain when they're admitted with PE. There is a lack, or there's often a delay in initiation of anticoagulation. And so therefore, I think we really do have to think about managing these patients appropriately when they present. We often get calls regarding these patients and what to do. And of course, suffice to say that some patients can actually tolerate quite a significant clot burden as well. So that's why it's particularly important to have a team behind you to help assess these patients when they present. So they're often hemodynamically stable, but you may often see on the CT report that there's an increased RV to LV ratio, or you have had an echo that tells us that these patients do have signs of right ventricular strain. And the reason we worry about these patients who do have signs of right ventricular dysfunction is that they often do have poor outcomes. And in some studies, the reported mortality is anywhere up to 15% and possibly even higher in some of the more recent studies that have been published. So Raza has already alluded to this assessment of patients who come in and trying to categorize them according to their mortality. So for those patients who do fit into the intermediate risk criteria, they are patients who appear to be hemodynamically stable for now. They have a high PESI score, so you already have imaging that tells you they have significant clot burden. And once you've done your PESI assessment, they fit into the high risk PESI scores. And they also have signs of right ventricular dysfunction, either on echo or CTPA in association with elevated cardiac troponin levels. And we know that an elevation in the cardiac troponin is particularly predictive of poor outcomes. So for those patients who fit the intermediate high category, they have all three of these issues. So high PESI score, right ventricular dysfunction, and elevation in cardiac troponin levels. So going back to this slide, which you've seen already, how do we manage these patients? So what should we do with these patients? So the ESC guidelines suggest that for all patients that present with intermediate risk PE, that we consider at least hospitalization, and for those patients who are fitting into the category of intermediate high risk, that we then think of other strategies in addition to standard management with anticoagulation, and they include reperfusion therapies. So we've already discussed that for patients who present with PE, in most patients who require hospitalization, they'll receive some form of parenteral anticoagulation, usually low molecular weight heparin these days. And we all, of course, appreciate the difficulties in maintaining a therapeutic APTT or anti-10A in patients on unfractionated heparin infusions. But now we have all sorts of other options that we can consider in managing these patients who present with intermediate high risk PE. So we have the potential to use half-dose systemic lysis, catheter-based therapies. So for those of you who have an interventional radiology department and are lucky enough to have a lot of the access to a lot of these therapies, we have the options of using catheter-directed thrombolysis, ultrasound-assisted thrombectomy, or thromboaspiration. So there's lots of development in this area in the last few years particularly, and we have access to many different types of catheter-based therapies, some of which involve a lower dose use of lytic, so potentially have a lower bleeding risk, and some of which, so for the thrombectomy devices, which Narayan will talk to you about a little bit later, may not even use any lytic at all. So there's a potential benefit for those patients in whom we're concerned about a bleeding risk if we are going to recommend they have some form of reperfusion therapy. And then, of course, we have the options to perform ECMO or surgical embolectomy for those patients who become very hemodynamically unstable. So why should we intervene though? And I think suffice to say, for a lot of us, the jury is out in terms of the data and outcomes for these patients in whom have had some form of reperfusion therapy. And there's still a lot of ongoing work in terms of clinical trials. So for now, I think it's particularly important that we really do consider patients on a case-by-case basis. So when we do consider those patients who have intermediate high risk PE and have a significant risk of a poor outcome, the reason why we should potentially intervene is that we know in the acute setting by giving them some form of reperfusion therapy that we can improve pulmonary perfusion and right ventricular function and therefore reduce the clot burden, and in the acute setting decrease the pulmonary hypertension risk. But I think where a lot of the issues lie in terms of data for these therapies is that we don't often know the long-term outcomes as to whether or not these reperfusion therapies decrease the risk of pulmonary hypertension in the longer term. And also there's a lot of recent discussion about patients who now have post-PE syndrome. So they've been screened for CTEPH. They don't have signs of elevated pulmonary pressures, but they have ongoing issues of shortness of breath and not really being quite back to baseline before they had their PE. The main concern is with these therapies particularly is obviously the risk of bleeding. And when we look at the data from the MOPPET and PITHO trials, the risk of hemorrhage significantly increases above the age of 65, particularly intracranial hemorrhage. And for now, the catheter-based therapies, while they offer the potential of lower dose lytic agent, or in some cases no lytic agent, there's a potential for a significant decrease in bleeding. But as I've said before, the problem is we're still not quite there in terms of the data. So I think for now, we really have to consider restricting intervention for those patients who we feel are at the highest risk of a poor outcome when they present with their intermediate high risk submassive PE. Not to forget, of course, that in some cases, these patients can present during pregnancy, and certainly this is an area where the data is even less clear, and very much we need to consider these patients on a case-by-case. There are some case reports of the use of thrombolytic agents in patients who have deteriorated with an intermediate high risk PE, and so far there have been no maternal deaths associated with thrombolysis, and most bleeding events seem to be associated around catheter and puncture sites and no reports of intracranial bleeding. But I think definitely this would have to be considered by an expert team in a patient who presents in PE. So because of all of the new data that we have on management of PE and all of these new options for reperfusion therapies, there has been a great drive in the development of what we call the PERT teams, so PE response teams. And they were first developed in around about 2012, so almost 10 years ago at this stage, mainly in the US, and they were developed to coordinate and expedite diagnosis, as well as try and coordinate and manage treatment of PE. They've already been shown to improve time to PE diagnosis and initiation of therapy. So where there are evidence of a PERT consortium or a PERT network that works very well, there has been a decrease in the cost of patient care, decrease in length of stay, and in some studies, even a decrease in mortality. And so in some guidelines, there have been a recommendation, including in the ESC guidelines, that if you have the potential to have resources available to you, that you should consider setting up a PERT network where possible. This, I think, is a really nice illustration from a recent publication from Rachel Wasowski. So she's done a lot of work in setting up the PERT networks in the US particularly. And coloured here in red are countries or regions where there are more than or there are at least one PERT network set up. So you can see obviously in the US and Canada there have been a significant number of PERT networks set up. Here in the UK and Ireland, there are already some PERT teams established, and I know as well as our team at Guy's and St Thomas's, there's a team already working in Cardiff where RASA is based, as well as many other centres around the UK. Europe, other European countries have developed PERT networks quite nicely as well, and suffice to say that there's still a lot of work to be done in terms of establishing PERT networks around the world. So just to discuss a little bit around our experience at Guy's and St Thomas's. So we first set up our what we call the PELT, PE lysis team service approximately 5 years ago, 5-6 years ago. And that was mainly because we recognized that patients' care for those patients who present with PE was extremely variable and pretty much depended on the team that they were admitted under. So we set up a multidisciplinary team made up of us as hematologists, some chest physicians, our interventional radiology colleagues, which are obviously critical to the PERT team, cardiologists for echo interpretation, critical care, and obstetrics. We also have a cardiothoracic surgeon available to us as well. We have started to really see an increase in number of referrals, particularly external referrals to our PERT service, because obviously we recognise that a lot of hospitals outside of a big central teaching hospital don't have the expertise or the facilities available to be able to consider different types of reperfusion therapies. So on a practical level, when we receive a notification of a new PE case for assessment, so PELT activation. So we use an app called Pando, which I'm sure many of you who work in the NHS may have access to, and it's acceptable in terms of data and GDPR. So we get a PELT alert, or one of us who's been notified. We as a thrombosis team are the sort of gatekeepers, as it were, at Guy's and St Thomas's. So we receive the initial referral, we put an entry on our Pando app, and that notifies our MDT or PELT MDT that we have a case that we need to discuss. I think suffice to say that a lot of the time the initial clinical assessment really is quite critical, because often you'll find that these patients just have a really significant clot burden on their imaging, but in actual fact they don't fit the category of intermediate high risk, because often their markers of right heart strain are normal. So it's really important to make sure that you have that thorough assessment of any right ventricular dysfunction. We'll recommend that all patients have an echo. Bilateral leg Dopplers can help, and there is some data that suggests that if you have significant iliofemoral clot on imaging, that further increases your risk in terms of poor outcome if you've got intermediate high risk PE. We obviously do a bleeding assessment risk, and then we set up an MDT discussion around whether or not we think the particular case is suitable for thrombolysis. I think suffice to say that in a lot of these cases, because they are hemodynamically stable, you have time on your side. So it's really important not to sort of jump in and treat the numbers, as it were. Give them the benefit of the doubt of having at least a few doses of low molecular weight heparin and see how they go. Now, obviously, if they start to deteriorate in terms of cardiovascular deterioration, then that may push you towards needing to consider a reperfusion therapy. But I would suggest that you definitely perform serial assessments and consider whether or not these patients do need to have an intervention. And importantly, it's really critical to involve the patient in your decision making, because a lot of these are new therapies without a lot of data in terms of longer term outcomes. So it's really important that patients are involved in any decision making along the way. This is just some preliminary data sort of showing you how many referrals we've received via our PELT network at GSTT over the 5-year period between 2017 and 2021. Of course, bearing in mind that we have some COVID years in between. But we've received or managed over 90 referrals. 30 of which were external. And you can see that approximately 2/3 of those patients have had some sort of intervention. Patients who went on to have full dose thrombolysis or because they deteriorated and became high risk PE. The other patients that were referred to us often from an external setting, and it might appear that we do seem to be a little bit trigger happy, as it were, in that a lot of patients have received intervention, but I think you'll appreciate that by the virtue of these patients being referred, they're already, pretty high risk in terms of their right ventricular dysfunction. So certainly we do consider each case on a case-by-case basis. In terms of outcomes or highlights of our service, in most cases, we will have an MDT discussion on the day of the PELT referral, and usually that's within at least an hour or two of the patient being referred. Of course, the issue being is that we've got no funding for this service. So at the moment, it's sort of kind of 9 to 5, Monday to Friday, but bearing in mind we as a thrombosis team and have an on-call thrombosis service, or the gatekeepers often will manage these patients out of hours, and usually our interventional radiology colleagues are particularly helpful and are always helping us in terms of how and when to manage these patients. Again, just to reiterate that I think it's critical to have the MDT approach, and certainly in a lot of these cases, we really value the input of our colleagues to help us determine whether or not it's appropriate to intervene. And preliminary data from our cohort looking at longer term outcomes suggests that for those patients who've had catheter-directed thrombolysis, we haven't yet seen any cases of CTEPH so far. But suffice to say that we still need, longer follow-up and more analysis of our cases. And we've also seen a trend to a shorter length of stay for those patients who have had an intervention. But of course, setting up a PELT service is not without challenges. And as we've discussed already, the concern is that we still have quite a way to go really in terms of establishing the data for the reperfusion therapies. So the concept for some people is a little bit difficult to accept when there is still that question around outcomes and improvement in outcomes with the use of these therapies. I think for us, the ownership of the service particularly can be sometimes a little bit tricky because colleagues, often their day is taken up managing PELT referrals. And for us, on a practical level, it's not just managing the patient and whether or not they need a reperfusion therapy, but it's the logistics of whether they need a transfer from another center, do we have beds, all of those concerns whenever you're trying to manage these services. So I know it certainly varies depending on which center you work in. In some centers, it may be a cardiologist that runs the service. In other centers, it may be a chest physician. So I think that often can be quite difficult in terms of setting up and managing the service. The pathways, of course, always need refining, and we're constantly learning. So, particularly for those patients who come from an external center, often what you've been sold, as it were, in terms of how the patient is can be very different to how that patient is when they arrive. So I would recommend that those patients at least come to a high dependency unit bed, and also, making sure that the referral is appropriate. And of course, as always, funding is difficult, particularly in this era, and it is not as yet a commissioned service. So just very briefly then, once you've managed these patients in the acute setting, I think it's really important also to have some data in terms of longer term outcomes. So not only considering the duration of treatment for these patients, but also at 3 months, thinking about whether or not they're still symptomatic from their PE presentation, performing screening for CTEPH, or post-PE syndrome in these patients is really important so that we can consider how these patients are managing in the longer term. So back to our case of the 63-year-old lady who presented on Friday, and suffice to say that sometimes how the numbers appear are not always how the patient is in reality. So when we saw the patient, she actually seemed quite comfortable lying in bed. She needed no oxygen support. She was not tachycardic. So despite how her images looked, the possibility of the right ventricular thrombus, she wasn't particularly clinically unwell. And when we asked our cardiology colleagues to review the echo, in actual fact, she did not have a right ventricular thrombus. She had really quite prominent right ventricular trabeculation. And when we reviewed all of her images, particularly looking at her femoral vessels, the clot was non-occlusive. So we felt that actually, given the fact she'd been in bed for over 6 months, literally really had not moved, not even to go to the bathroom, that this is very likely to be chronic, and that her blood pressure was actually normal for her given her immobile status. So she was managed with anticoagulation alone, and when we checked in yesterday, she was actually doing quite well. So I guess to finalize and in summary really around the management of these patients who have intermediate high risk PE, the future is bright. You know, certainly there are lots of different options, and I think we will probably be in a very different place in 5 years, but we do need more data in terms of outcomes for these patients who have reperfusion therapies. It's important that we continue to optimize the PERT services, particularly the external referral pathways, and often we find it quite difficult to collate and look at all our data. So the use of these AI tools are coming on stream now, where you have the facility to have all of the data together and be able to discuss these patients with external centres. And it may well be that we can hopefully establish some PERT networks within the UK for those patients who need discussion of management of PE. So with that, I will say thank you very much for listening. And this is just our lovely PELT team at Guy's and St Thomas's.